Well, thank you everyone for joining us today or this evening. Welcome to the Dartmouth Club of Washington, D.C.'s 2020 Virtual Webster Award. My name is Yasuto Shah. I'm a member of the class of 2015, and I'm the current president of the D.C. Club. We're so pleased tonight on the eve of Veterans Day to be honoring veteran Dr. Gerry Cox, Assistant Undersecretary for Health for Quality and Patient Safety, Veterans Health Administration, the U.S. Department of Veterans Affairs, and a proud member of the class of 1979. The board of directors selected Dr. Cox as the recipient of this year's Webster Award last winter, and we fully intended to put on a large dinner event as we typically do, but COVID had other plans, as has so often been the case this year. As we worked with Dr. Cox to determine a way to honor him in this virtual environment, we determined that the circumstances presented a unique opportunity to partner with the Dartmouth Uniformed Services Alumni Organization, otherwise known as DUSA, since their members could join us from anywhere. And so we worked with Dr. Cox to add a charitable donation portion to this evening. And I wanted to note that through your generous donations, we've been able to raise over $1,200 for DUSA's Student Scholarship Fund. And we're very pleased to be able to support them in this way. Additionally, we've developed a unique program for this year. We will have a presentation of the award by Dr. Cox's classmate, Dr. Frazier, who himself has a long history of service in medicine and healthcare, and he currently is a leader at the George Washington University School of Medicine and Health Science, where he is Associate Dean of the Graduate Medical Education and Professor of Urology. We will also have remarks by Kate Sullivan, class of 2013 and president of DUSA, who was commissioned as an officer in the United States Marine Corps after graduating from Dartmouth in 2013. And finally, we will have a panel moderated by Susan Dentzer of the class of 77. She's a proud member of the Dartmouth Club of Washington, D.C., and a past recipient of the Webster Award herself. Susan will be joined by Drs. Cox and Frazier, as well as current Montgomery Fellow, Dr. David Silbersweig, class of 82, Chair, Department of Psychiatry, and co-director of the Center for Neurosciences at Brigham and Women's Hospital. We hope the panel will give interesting insights as to how systems, organizations, and individuals have responded to COVID, both as a threat and as an opportunity. But before we begin, I'd like to thank the award committee members for their adaptability in pulling together a virtual event. In particular, I'd like to thank Meredith Benedict, Alex Jarvis, and Liza Catucci, who worked very hard to make this happen. And I'd also like to note that we hope to host Dr. Cox and a to-be-named 2021 Webster awardee at an in-person event next fall. With that, I'll turn things over to Meredith Benedict, this year's Webster Committee Vice Chair. Meredith, are you able to unmute yourself here? Give Meredith just 1 second. And if not, Meredith, are you able to unmute there? Then I will go ahead and continue here. So Meredith's remarks were to just provide a bit of history on the Webster Award. So I'll provide that history here for those who haven't joined us for one of these in the past. The Dartmouth Club of DC was founded in 1876 and is one of the largest in the country. I believe it's the 4th largest alumni club in the country. We're pleased to reach nearly 4,000 alumni in the region with our programming, and we've had the tradition of bestowing an annual award in recognition of significant and distinguished public service by a Dartmouth alumnus or alumna with a connection to DC since 1988. The early awards focused on recognizing government service, and over the years, though, we have expanded to include alumni in the nonprofit sectors. The selection criteria, of course, are that they are a graduate of Dartmouth, but also that they have a record of significant public service and or public policy accomplishments, and that the accomplishments may be at least in part during employment by a government or a nonprofit organization in the DC area. And finally, that the awardee has demonstrated exemplary personal values and leadership qualities. The club names the award in honor of alumnus Daniel Webster, class of 1801, whose distinguished career included government service as a representative for New Hampshire, representative and senator from Massachusetts, and Secretary of State in 2 administrations. He was truly a remarkable public servant and a loyal alumnus of Dartmouth. For so many of our awardees and for so many alumni, public service roots were seated in their time in Hanover. Each year, as club members nominate fellow alumni, the committee is humbled to think of the contributions so many from Dartmouth have made, regionally, locally, and nationally. Dr. Cox's service as a combat veteran and for decades in the Veterans Administration stood out for us this year. And now, with the role of medical leaders and health systems in the wake of the novel coronavirus, the choice seems especially apt. Through his career, Dr. Cox has contributed to the safety and quality of care received by millions in our military during their service in combat and as veterans. As you will learn this evening, his career in medicine and in the military began at Dartmouth with a recruiting event in the Hanover Inn. And with that, I'll turn it over to his classmate, Hal Frazier. So Hal, if you want to go ahead and share your screen.
Go. Well, it is a distinct honor and a great pleasure for me to be here this evening. So thank you for the invitation to be able to introduce our distinguished recipient of the 2020 Webster Award. Dr. Gerry Cox and I were fellow members of the class of 1979, and he remains a dear friend to me to this day. Gerry and I have known each other a long time. In fact, I think our friendship goes back to the days of Daniel Webster, right? Or at least it feels that way at times, right, Gerry? Anyway, Gerry and I spent a lot of time together at Dartmouth, taking many pre-med courses. He was a biology major, I was a chemistry major. We took biology courses together. We took 2 chemistry courses. We took 2 physics courses. We took 2 organic chemistry courses together. We spent a huge amount of our time in the same classes together. And we were such nerds. We had labs together. We used to wear those big old glasses, those big old dark glasses. We called them birth control glasses, or BCGs for short. They're pretty ugly. But coming out of high school, I thought I was a big deal. But once I got on Dartmouth's campus, I was happy to be in the kind of the middle third of our classes. Gerry, though, on the other hand, continued to be a big deal. He did great in classes, and he was a big man on campus. I loved listening to his radio show on their college radio station. He was the chief announcer for WDCR. He was so cultured and sophisticated and suave, which was fun for me because I was just a redneck from Ohio. And, you know, it's kind of fun to hang out with them. Several of our female classmates expressed to me that they wanted to meet him, but Gerry was too focused on his studies. As I said, we were both pretty nerdy, which was probably a good thing because he later met a wonderful, magnificent woman, Kathy, who he later married after his internship. Gerry is a very impressive man. He's a doctor, he's a flight surgeon. He qualified as a surface warfare officer. He's a Navy captain. He's a commanding officer. He was an inspector general, assistant undersecretary of the VA. You can read his bio. The list goes on and on. It's pretty extraordinary. But let me share a few personal thoughts about Gerry that I know and love. After leaving Dartmouth, he completed medical school at UMass, and he went to officer indoctrination school in Newport, Rhode Island. We call it the Fork and Knife School, where we learn how to behave as officers. Then he was commissioned as a lieutenant after graduating medical school in 1983. He completed his internship at National Naval Medical Center in Bethesda in 1984, and then flight training in Pensacola in 1985. Soon thereafter, he married Kathy, who's an absolutely wonderful person. She's smart, gorgeous, gifted, funny, and loving. Come to think of it, Gerry, you married up, you know. So Gerry served as a flight surgeon for many years. He was, these are photos of Gerry in an A6 Intruder. He served time a couple of operational air wings as their doc. He then went on to finish an emergency medicine program at GW, which is where I'm one of the deans at this point. And he spent time at Georgetown at University of Maryland. He was mobilized for Desert Shield and Desert Storm in Saudi Arabia. He served with Fleet Hospital 5 in Saudi Arabia. And then he went on to serve as senior medical officer in USS Enterprise in 1982. Over the next 8 years, his career blossomed and he stepped into the stratosphere where he was promoted to serve our commander-in-chief. He worked at the White House medical staff during 2 different presidencies. This is a great photo on the left where he was promoted to captain aboard Air Force 2 with Vice President Gore. And then he was very close to Bill and GW, as you can see by these photographs. After his time in the White House, he moved back into the operational theater, serving in Operation Enduring Freedom. And this is a photo of him in Kabul, Afghanistan. Gerry retired in 2013 from active service in the US Navy after 30 years of wonderful dedication to our country. That's a huge list of awards, and he continues to serve our veterans even to this day in the VA system. I am personally so proud of him. Our career paths have intertwined frequently over the decades. I went to Dartmouth where we studied together. I served 25 years in the US Navy, frequently seeing each other throughout our career. We both worked in the VA, and we share a common bond with GW. So as you can see, he and I have a very incestuous relationship. Very few people realize that Gerry and I actually shared the same bedroom at one point. Now, I know it sounds scandalous, but let me explain. When Gerry finished his internship at Bethesda Naval Hospital in June of 1984, I arrived at Bethesda in June of 1984 to start my internship. As he moved out of the house on Maple Ridge Road in Bethesda, Maryland, I moved into the exact same room where he was vacating. So we are really close. We had a very unique home group of people living with us, didn't we, Gerry? We had a nurse, we had a fireman who ran the Bethesda Rescue Squad. We had a lumberjack, tree surgeon. It was a very eclectic group of people and very stimulating to live with them. Anyway, Gerry has dedicated his life to excellence in everything he does. He believes in serving people. He and I have talked a number of times about servant leadership, and he absolutely believes in this ideal. It's not so much that he's interested in the title as it is how can he contribute to the greater good. Quite frankly, we could use more people like Gerry right now in Washington, D.C. The other thing that's notable about him is he's a loving husband, a doting father, and a passionately loyal friend. Gerry is someone that I aspire to be when I grow up. So Gerry, I'm very proud of you, and I'm thrilled to be here this evening, and I'm also blessed to call you my friend. So ladies and gentlemen, a true patriot, a devotion to God and country, a man of Dartmouth with granite in his muscles and his brains. Dr. Gerry. Thank you.
Thank you, Hal.
My pleasure.
There we go. Over to you, Gerry.
Hey, Yasuda, so you want me to give my remarks now, or was Meredith going to make a presentation?
Oh, yes, that's right. Sorry, Meredith, are you, let's go ahead and do your remarks now, and then we can do the presentation immediately afterwards.
Okay, great. Well, good evening, everybody. Yasuda, thank you very much for the introduction, and Hal, thank you so much for being my lifelong friend and for that wonderful review of our lifelong relationship and professional career together. This is an incredible honor for me, an incredible night for me and my family. My wife, Catherine, and our 2 children are both among those of you who are viewing tonight, as well as my brother, Tim, and his wife, Joy, out in Colorado, and some other family members across the country. So I'm just thrilled and humbled to be receiving this recognition tonight. I want to thank the Dartmouth Club of Washington, D.C., including Yasuda Shaw, our club president, Alex Jarvis, the Webster Award chair, and Meredith Benedict, who's actually the one that's been working with me since early in 2020, pre-COVID, just before COVID began, to prepare for this evening. Hal, I don't know where you got some of that information. It was some pretty incredible stuff. I particularly love looking at the old photos. But one thing that Hal didn't mention is that in addition to all of our professional and personal achievements and what we shared over the years, Hal actually performed surgery on me at one time. I don't know if you remember that, Hal. I think you might have still been chief resident at Bethesda around 1989, when Kathy and I were struggling with infertility, and Hal's a urologist. You can imagine that he knows me actually more intimately even than he was able to let on. I also want to thank DUSA and President Kate Sullivan, class of 2013, for agreeing to be part of this evening's event and for all the great work that they do on behalf of student veterans at Dartmouth. I also need to acknowledge that today, November 10th, is the 245th birthday of the United States Marine Corps. So Semper Fi, Kate, and Marines all around the world, happy birthday to you. Somebody mentioned the restrictions imposed by COVID and the fact that we had hoped to have a face-to-face in-person event this year. The fact is that the pandemic is now exploding across the country. It's no longer confined to particular regions. As you know, 48 out of the 50 states are seeing increases in the number of COVID cases. And so there's rampant community spread going on. I am a little hopeful after the news this week about the promise of an effective vaccine that could be available in the next few weeks or months, that we will eventually get past this. And it would be wonderful if we could all be together in person at a traditional Webster Award dinner next year. I am deeply humbled to be in the company of so many past award recipients, including United States senators, multiple members of Congress, distinguished journalists, including our own Susan Dentzer, class of 77, cabinet officials, career diplomats, prior presidents of Dartmouth, and of course, one of my personal and professional heroes, former Surgeon General of the United States, C. Everett Koop. So I am truly humbled to be numbered among that group of incredible people. I'm sort of an accidental military guy. I never intended to make the Navy a career when I graduated from Dartmouth. I often say, only half jokingly, that I joined the Navy for the money. And the truth is, that was the case. Yasudo alluded to the fact that some medical recruiters from the Boston recruiting district came to Hanover during my, must have been early senior year. And I came across a poster somewhere about coming to hear a presentation on the Navy Health Professions Scholarship Program. It's a program that still exists today, and it was a terrific deal for me and actually made all the difference in my life. The HPSP gives you a full ride to medical school. The military pays for all your books and fees and gives you a living stipend in exchange, of course, for a service obligation. I grew up in a fairly humble middle-class background. My dad was a journalist, my mom, a small-time radio announcer for more than 50 years. And they really struggled to send me to, first of all, to parochial high school, and then especially an expensive private college like Dartmouth. Now, when I say expensive, I think in 1975, when Hal and I matriculated, the tuition was something like $6,000 a year, not a semester, a year. But that was a lot of money back then. My folks took out loans. I was on a work study. And when I, 4 years later, decided to go ahead to medical school after deciding to pursue that career, I didn't want them to sacrifice any further. So I wanted to find a way to pay my own way, and the Navy provided that. I remember also reading the recruiting brochures, right? The propaganda that the Navy put out about this thing called being a flight surgeon, which is a traditional term, has nothing to do with performing surgery, but it's an aviation medicine specialist. There was a particular brochure I remember seeing with a guy in gleaming white uniform standing on the deck of an aircraft carrier with his hands on his hips, gold wings on his chest. And I said, someday I want to be like that guy. So that's how I ended up pursuing that part of my career. I also particularly remember meeting with then Dean of the college, Ralph Manuel, who was not only our dean at that time, but who was a commander in the U.S. Naval Reserve. And he had to endorse my application for the Navy scholarship. So thankfully, it was the only time I ever got summoned to the dean's office, but he was very kind and was instrumental in helping me pursue that career path. So I joined the Navy with the intention of doing the 4 years of payback and then going back to Massachusetts to probably go into private practice, do something traditional. My late mother, sorry to say, never did see that come to fruition. I think she was still hoping it was going to happen right up until her death a couple of years ago. What really happened is I served about 3/4 of my obligated service. Then I went back into residency. I did the emergency medicine program at George Washington and Georgetown and the University of Maryland that Hal referred to, and that added additional obligations. So eventually I had 11 years of active duty and it had gone by just like that. And I realized I'm more than halfway to that 20-year mark where still today you can retire with a lifelong annuity from any branch of the service. The other thing besides the benefits and the promise of a retirement that the Navy provided is the opportunity to change jobs every 2 or 3 years. You know, people normally rotate, called routine change of station orders. So every time you do that, if you look for the right opportunities, you can acquire a whole set of new skills. You meet new people, you learn new jargon. And I learned stuff that clearly they don't teach you in medical school about the organization of a squadron, about the engineering and navigation systems on a ship like USS Enterprise. Like when I eventually rose to the point where I was running hospitals, I knew nothing about medical supply or facilities management or financial management, all those kinds of things. But you surround yourself with good people and you learn who you can trust. It's that lifelong learning opportunity that the Navy provided that kept me interested. I guess, you might guess, being an emergency medicine specialist where you have to know a little bit about a lot of things, I have a fairly short attention span, and that probably served me well in the Navy too. I didn't follow a traditional career path. On the contrary, as I got more senior and the opportunities for assignments got more interesting, I took some strange left turns, and as Hal mentioned, was an assistant inspector general, was creating health policy on the staff of the Navy Surgeon General here in Washington 20 years ago, was the #2 physician in the United States Marine Corps for 3 years, eventually became the leader of a couple of naval hospitals, and then oversaw combat medical support in Kuwait and Afghanistan about 10 years ago. The Navy also afforded a culture that I found welcoming, a culture based on service and selflessness and the core values of honor, courage, and commitment. So after 30 years, when eventually they kicked me out and they said, Gerry, it's time for you to go in 2013, it was a natural transition for me to move into the Department of Veterans Affairs, where I was very fortunate to be offered a leadership role and not plan on spending anything like 7 years there. I thought it was just going to be something to do for a while figuring out what else to do. But the VA has been a very good fit, and it's an honor for me to be able to continue the mission of caring for America's veterans. The other thing the Navy gave me, as Hal mentioned, is my best friend, my lifelong partner, and my wife now of nearly 35 years. I met Catherine during the very first month of my internship in July 1983. She was a beautiful young nurse, an ensign, so the most junior the officer ranks, working in the intensive care unit at what was then called the National Naval Medical Center, Bethesda. Now it's Walter Reed National Military Medical Center. We started dating about halfway through that year in December. We got engaged the following December, and we planned to marry the next summer, but the Navy had something else to say about that. They sent me to Japan for 6 months. So we ended up getting married in December of 1985. So 35 years coming up in a couple of months, actually less than that, several weeks now. After 2 tours on active duty, Kathy herself joined the reserves, and she continued to serve for 30 years, retiring as a captain in the Navy Nurse Corps the same year I did in 2013. So I'm so proud of her for that. I'm so proud of what she's doing now as a tenure track associate professor on the faculty of the George Washington University School of Nursing and Health Sciences. She has been with me through all the ups and downs, and believe me, sounds glamorous, but there were plenty of downs as well as some great ups during the last 35 years. So she's been my lifelong partner. We've raised 2 incredible kids. They're both also on the call tonight. My son Alex attended another small liberal arts college in Cambridge, Massachusetts, and now there he is, and there is actually just started a couple of months ago in graduate school at Harvard. He's working on a master in urban planning, another public servant, spent the last 4 years working for the state, the Commonwealth of Massachusetts, and Massachusetts Department of Transportation, and now is pursuing his dream to be a planner of transportation systems. And our incredible daughter, Caroline, is a senior at the College of William and Mary, and she's double majoring in neuroscience and German. And there she is. Hi, sweetie. And actually, she is going to go to medical school soon. She's already been accepted at least one and still waiting for some other applications to go through. So we are incredibly proud of both of our kids. I must say, Dartmouth declined to offer admission to either one of them when they applied as undergraduates. Caroline did get on the waiting list at least, but points off to the Dartmouth Admissions Committee for that. It is fair to say, in short, that I would not be here tonight without the incredible support and love of my family. So thank you, guys. I love you. People often ask me which Navy assignment was the one that I enjoyed the most. And I had so many great experiences and so many unusual opportunities. It's really hard to say. I mean, certainly our 2 overseas assignments were fantastic. We spent 2 years living on the subtropical island of Okinawa, Japan, which is a large United States Marine Corps installation, as well as a big Air Force presence, something like 50,000 U.S. military troops and their families live on that little island. And I was at that time the second in command of the Navy's largest overseas naval hospital. But beyond that, it was a terrific family experience for all of us. And we traveled across the Far East and we had wonderful cultural experiences. Then a few years after that, we went back overseas, this time to the Middle East. I lived in Bahrain. We lived in Bahrain. The whole family, kids attended the Department of Defense school there called the Bahrain School, which took in students from more than 40 countries from around the world, Arab countries, I should say, as well as children of expatriates and diplomats from Europe and South Africa and all over the world. So another pretty incredible experience, another great travel opportunity for us. When I was at home, some of the time when I wasn't at home, it was because I was in and out of Afghanistan quite a bit, which I thought at the time was probably the most impactful assignment that I had, directly supporting combat operations in that war. Being selected for hospital command is a big privilege. You know, you have to go through multiple screening processes and boards of senior officers to be given the opportunity to be a commanding officer. So that was a great privilege. But I'd have to say, if you ask me what the most memorable assignment was, it was my 2 years as a White House physician. And you saw a couple of the photos there from those times. It was absolutely a unique opportunity to be in the front row, have a front row seat in the making of history. And particularly during these last few weeks and all of the discussions surrounding the presidential election of 2020, I think back 20 years ago, to the election of 2000. My first year as a White House physician, they let you practice on the vice president. That's not entirely an exaggeration, but I was assigned quite frequently with Vice President Gore, who was first a candidate and then eventually the nominee of the Democratic Party for president in that year. And so from 99 to 2000, I was often asked to accompany him on Air Force Two as he was campaigning 6 days a week. He'd be out in places like New Hampshire and Ohio and Iowa and Florida, and actually probably wishes he spent a little more time in Florida in retrospect. But it was an incredible opportunity to see a national campaign from the inside. And then that election of 2020 that nobody won for about a month, a little bit similar to this year's situation, although at that time it was just one disputed state count, the vote in Florida. We all remember the recount and Hain, Chads, and all of that. And then eventually the Supreme Court had determined that the recount had to stop and declared George W. Bush the winner. And then I was there at the Capitol, standing below the temporary stage at the Capitol on the day of his inauguration, President Bush's inauguration in January 2001. I have a distinct memory of then going back to the White House while the post-inauguration luncheon was going on in the Capitol, standing in the West Wing right outside the Oval Office in what used to be the appointment secretary's office. Remember the name Betty Kerr? She was President Clinton's appointment secretary. So in that office, it was vacant because there's a wholesale turnover of the entire West Wing and entire White House residence every time one president and his family move out and another one moves in. And so standing in the appointment secretary's office that day, all the furniture was pushed into the middle of the room. The walls had been repainted. The computers were all unplugged and sitting on top of desks. But in the corner, there was an old-fashioned console TV and the power was on. It was on one of the news cable channels. I can't remember if it was CNN or something like that. And there was a split screen image on that TV at that moment. And on the left half of the screen was an image from Andrews Air Force Base, where now former President Bill Clinton and his wife, Senator-elect Hillary Clinton of New York, were preparing to depart and fly to Chappaqua, where they were going to take up residence in a big blue and white airplane that was no longer going to be called Air Force One because he was no longer president, but had some ordinary call sign. And he was lingering at Andrews, I think, soaking in the last moments and savoring the chance to shake a few more hands. Meanwhile, in the other half of the screen, an image of the incoming president, the newly elected President George W. Bush, in a brand new presidential limousine at the head of a motorcade that was just starting its way down Pennsylvania Avenue from the Capitol towards the very spot where I was standing, toward the White House. That memory is indelible. I will always remember that moment and think about what an historic time that was in our nation's history. Maybe not as historic as the times we're living through now, but pretty close. I got to talk for a minute about my current work at the VA. As I said, I wasn't planning on pursuing a second career after I retired from the Navy, but I've been very fortunate to find meaningful work with the Veterans Health Administration. It was really a natural transition, and now I've been there almost 7 years. held several leadership roles during that time, which just tells you I have trouble holding on to a job. That short attention span thing again. And I have to admit to you that federal government service is not always easy. And it has certainly not been easy during these last few years. But it is a privilege to continue to serve those who have worn the cloth of our nation. I got to tell you also, I didn't learn any of this in medical school. Al told you, I was a biology major. I was a science nerd. I should have taken some more civics courses. I should have paid attention to more history and government. I took exactly one government elective at Dartmouth. Some of you might remember Professor Larry Radway, who was a kingmaker in Democratic politics in the state of New Hampshire at that time. I think I was a senior when I took that elective. I remember he gave me a B+. I remember that lowered my GPA just a little bit. And so that was the last government course that I took. I stuck with science after that. So it's nice to share a few of these memories with you, but most of all, I want to again convey what an incredible honor it is to be numbered among the many unbelievable prior Webster Award recipients and to be sharing this experience with you tonight. I don't know if Meredith was going to ask me to display this, but she actually came to my home last night and dropped off the Webster Award in person. It's a beautiful, very hefty crystal obelisk engraved with my name and my class, Hal, our class of 1979. And I will treasure this, and this is going to take up a position of honor in my office at the VA headquarters. So thanks again to all of you. Thanks to the Dartmouth Club of DC, my lifelong friend and shipmate and medical colleague, Hal Frazier, for agreeing to take on the duties of introducing me at tonight's ceremony. Thanks again to Kate and DUSA for their important work. And most especially, thank you to my wonderful wife, Kathy, to our kids, Alex and Caroline, to our entire family, many of whom are with us this evening, for their unconditional love and support. I am deeply honored, and I thank you again.
Proud of you, Dad.
Thanks, son.
So this is Meredith. I'm going to see if you guys can hear me now. Can anyone hear me?
Yes.
Yep.
Yes, we can.
Oh, I don't know what is happening with my connection here, both of my computers and even through my iPhone. I'm not able to connect into the Zoom. So I'm just on by phone, and I do apologize for the hiccup. I was supposed to be joining you all to test run before we even started this event. So, and I restarted one of my computers, and I'm not sure if that's what caused it, but I wanted to congratulate you, Gerry, and thank you, Hal, for your introduction. What we missed, because they were part of my remarks, was the introduction of you, Hal, and I would love to just take a minute and dial back and have a chance to introduce you as a veteran yourself, and I wanted to acknowledge your leadership in medicine as a professor of urology and associate dean of graduate medical education at George Washington University School of Medicine and Health Sciences, and your clinical leadership of the urologic oncology program at GW Hospital and service on its board. As I read about your background, 24 years of service in the Naval Reserve and continuing work teaching active duty military personnel through the Uniformed Services University of Health Sciences. I think you also are a Dartmouth alum that has a very strong career of leadership and service, and I wanted to note that as well. And thank you again for your remarks about Gerry and your friendship and your time at Dartmouth as well. The next up on our thanks, Hal. Next up on our program, we wanted to give Kate Sullivan, class of 13, president of DUSA, an opportunity to speak for a couple of minutes. As Yasudo mentioned at the beginning of the call, when we determined that we were going to have this event and hold it on the eve of Veterans Day, and we were honoring a veteran. It was actually Gerry who suggested, we asked him if he'd like our donations from the virtual event to benefit an organization associated with veterans, and he immediately said DUSA. He would love that to happen, and it's been great to connect with Kate through the planning of this event. She majored in psychology and English creative writing at Dartmouth and was co-captain of the cross-country and track teams. She also wrote for the D, performed stand-up comedy, and served as a head coach for a chapter of Girls on the Run. She, as a commissioned officer in the United States Marine Corps, she served with the 1st Transportation Support Battalion at Camp Pendleton as a platoon commander, executive officer, and ultimately company commander, leading and serving 152 Marines. She's represented the Marine Corps twice in the Armed Forces Cross Country National Championships, as well as the Warriors Across the Sea Championship. And her personal decorations include the Navy and Marine Corps Commendation Medal. She's a member of the Marine Corps Reserve, and she's currently living in New York City, where she's pursuing her MFA. So I wanted to welcome you, Kate, and thank you for joining us tonight and give you the opportunity to have a few remarks before we transition to the panel.
Thank you, Meredith. It's a complete honor to be here. Hello to everyone in virtual attendance. And thank you so much to Yasuto, Meredith, Alex, and all of the club leadership for allowing DUSA and myself to take part in tonight's schedule of events in celebration in such of a storied leader and public servant. As Meredith mentioned, my name is Kate Sullivan. I'm class of 2013, veteran of the Marine Corps, and currently serving as the president of DUSA, the Dartmouth Uniformed Service Alumni. DUSA is a shared interest alumni group dedicated to promoting the ideals of service at Dartmouth and supporting all those who wear our nation's uniform in defense of country. We serve veteran alumni as well as current student veterans in attendance at Dartmouth's undergraduate and graduate programs. It is a particularly special honor to be here this evening in recognition of Dr. Cox, who in 2018 was selected as the recipient of our organization's annual James Wright Award for Distinguished Service. That award, named, of course, for Dr. James Wright, Marine historian and the 16th president of our college, is awarded to a member of the community who, over the course of a lifetime, has exemplified the ideals of service beyond self, an enduring commitment to the college, and a lifetime of distinguished service to nation or community in ways that promote freedom, empowerment, health, peace. Dr. Cox's lifetime of leadership in public and military service is nothing short of exemplary, and we remain honored that he is a part of this award's legacy and will continue to inspire generations of leaders, service members, and students to come, for years to come. On behalf of DUSA, our members, and the student veterans that we serve, we're humbled by the generosity of Gerry to our organization in donating tonight's proceeds to serving the student veterans. We will be able to use these funds to continue to support them in their ambitions in pursuing internship opportunities and providing engaging virtual programming for the student veteran community. This week, in honor of Veterans Day, some of the current student veterans will be partaking in a virtual storytelling event tomorrow morning and afternoon, sharing their stories of how they went from military service to arriving at Dartmouth. I've personally been able to serve as a volunteer story coach with them, and their stories are nothing short of inspiring. Additionally, DUSA will be hosting a virtual reading with National Book Award winner Phil Cly, Marine veteran in class of 2005, whose new novel Missionaries has just been published. We will be able to continue programming for the student community through the generosity of Dr. Cox and all those in attendance tonight. And if you are able to join us, you are most welcome to do so. The event links can be found on the college's Veterans Day website. Thank you so much again, and congratulations to Dr. Cox on this most deserved recognition.
Thank you very much, Kate. And I'll turn it over to another Webster Award committee member, Liza Catucci, to introduce the panel portion of the event.
Thank you again for those remarks, Kate. My name is Liza Catucci. I graduated from the Dartmouth Institute for Health Policy and Clinical Practice in the Geisel School of Medicine, and I'm a member of the Webster Award Committee. We now want to transition to the panel discussion portion of our event. I will turn it over to our moderator, Susan Dentzer, 77, in just a moment. But first, I'd like to provide an overview of the format for tonight's panel. Susan will ask questions of the panelists for the first 30 minutes and reserve 10 minutes for Q&A at the end. Please post any questions that you have in the chat throughout the panel, so that Susan may ask those questions of our panelists once the Q&A session begins. Thank you. It's now my pleasure to introduce Susan Dentzer. Susan Dentzer is a Senior Policy Fellow at the Robert J. Margolis Center for Health Policy, the Washington, D.C.-based arm of Duke University that focuses on health system transformation, biopharmaceutical policy, and other key health policy issues, including multiple aspects of the COVID-19 pandemic. Susan is one of the nation's most respected health and health policy thought leaders and a frequent speaker and commentator on television and radio, including PBS and NPR, and an author of commentaries in Modern Healthcare, the New England Journal of Medicine, and other prominent publications. She is also the editor and lead author of the book Healthcare Without Walls, a Roadmap for Reinventing U.S. Healthcare. Susan previously served as president and chief executive officer of NEHI, the Network for Excellence in Health Innovation, was senior policy advisor to the Robert Wood Johnson Foundation, editor-in-chief of the journal Health Affairs, and on-air health correspondent for the PBS NewsHour. She's an elected member of the National Academy of Medicine and the Council of Foreign Relations, and is a fellow of the National Academy of Social Insurance and the Hastings Center. She's a member of the board of directors of the International Rescue Committee, Research America, and the Public Health Institute. She also serves on the RAND Health Board of Advisors and the Independent Global Access Policy Advisory Committee for Roche. Susan graduated from Dartmouth in 1977 and served on the Dartmouth Board of Trustees from 1993 to 2004. She was the first woman nominated by the alumni body of Dartmouth to serve as a trustee. She went on to chair the Dartmouth Board of Trustees from 2001 to 2004 as the first woman and first Dartmouth alumna to serve in that capacity. She also served on the Dartmouth Medical School Board of Advisors, formerly Overseers, from 1993 to 2018. Susan is a former member of the Dartmouth Alumni Council, is a recipient of the Dartmouth Young Alumni Award and also the Dartmouth Alumni Award, received the Dartmouth Presidential Medal for Leadership, and holds an honorary master's degree from Dartmouth. She received the Daniel Webster Award for Public Service from the Dartmouth Club of Washington, D.C. in 2005. She's a frequent lecturer at both the Geisel School of Medicine and the Amos Tuck School of Business at Dartmouth. She also serves on the Board of Advisors of the Center for Global Health Equity at Dartmouth. She is currently pursuing the master's degree in healthcare delivery sciences at Dartmouth. Susan and her husband, Charles Alston, have 3 adult children, including Will Alston, a member of the Dartmouth class of 2016, who is currently pursuing his MBA at Columbia University, and daughter Grace Alston, a proud member of the class of 2022 at Dartmouth. I now turn it over to Susan Dentzer.
Well, thank you so much, Liza. And I'm very sorry that my mother got to you and made you read that entire biography about me, because it's obviously not about me tonight. It's about Gerry. And Gerry, congratulations. It was wonderful to hear your account of your distinguished career. So congratulations again to you and your family. And thanks also to Hal for that wonderful introduction, making you out to be a human being as well as the God that you clearly are with respect to all your service for our country and your service in medicine. I also want to say thank you to the Dartmouth Club of Washington, Yatsuto and Meredith and colleagues for making this a virtual event tonight. As we all know, the prominent way that COVID is now being transmitted is indeed in social gatherings and bars and restaurants. So by having this event virtually, you have saved us a super spreader event. And we're all very, very grateful for that. So thank you for adapting so wonderfully to make this a reality tonight. The audience has met Gerry and Hal already, so I'd like to start by introducing our third participant in this panel, who is David Silbersweig. a physician. He's chair of the Department of Psychiatry and of the Institute for the Neurosciences at Brigham and Women's and Faulkner Hospitals in Massachusetts. He's also the Stanley Cobb Professor of Psychiatry at Harvard Medical School and a pioneer in the field of functional neuroimaging research in psychiatry, which is designed really to figure out how the brain works well enough that we can develop very novel and targeted diagnostic and therapeutic strategies to aid those suffering from mental illness. Among his areas of focus are cognitive function disorders, complex neurologic diagnoses, and major depressive disorder. He's a proud member of the class of 1982 at Dartmouth and also a graduate of Cornell University Medical College. He did his residencies at New York Hospital Weill Cornell Medical Center, and he was scheduled to be a Montgomery Fellow at Dartmouth this year, but that has been time shifted due to the pandemic, so he'll be serving in that capacity, we hope, next year. And David, we will note that you are the only member of this panel who is not a member of the class, one of the distinguished classes of the 1970s, but we've decided to cut you some slack as a member of the class of 82 and be on the panel anyway. So thanks for joining us. So I'm really delighted to moderate this discussion now about a more sober topic, navigating COVID-19. And again, I invite the audience, as Liza said, to put any questions in the chat. And so all of you panelists, we know we're at a really terrible threshold in this at least now 11-month-old saga of COVID-19. We've surpassed 1.3 million deaths globally, close to 240,000 known deaths in the US. As of today, we have an all-time high of hospitalized patients in the US in excess of 60,000. We've seen huge disparities in illness and death rates across racial and ethnic lines, with some racial and ethnic groups up to 2 to 5 times more likely to experience illness, hospitalization, and death than white Americans. And as Gerry said, we're entering a very, very dangerous new phase of the pandemic, with a prediction that we could exceed more than 400,000 deaths by year end. And as Gerry said, we've had some good news this week with respect to very early but very promising results of one of the COVID vaccines under development. We also had, we see some emergency use authorization this week of some very effective therapeutics for COVID-19 in the form of monoclonal antibodies. So there are some reasons for hope. But as we have said, by the same token, we are in a very, very dangerous phase of the pandemic. And we know that that has all had very substantial repercussions in terms of the rate of jobless loss in the pandemic. We know that we are still hovering around a 7% national unemployment rate, and the unemployment rate is about twice as high for people in certain sectors of the economy, as well as among young workers, essential workers, and racial and ethnic minorities. So it's a very, very grim time. David, I wanted to start with you because as we know from the Centers for Disease Control and Prevention, as of late June, more than 2 in 5 residents of the US said that they were struggling with mental or behavioral health issues associated with the pandemic. Anxiety, depression, substance use, suicidal thoughts, etc. And about 1 in 10 of people actually said they had been contemplating suicide in the 30 days before completing the survey, with again, that rate almost 2.5 times higher for racial and ethnic minorities. So just a terrible, terrible additional set of effects from the pandemic. From your perspective in psychiatry, what are we doing to mitigate this, and what must we do to mitigate this, if not prevent this phenomenon as we continue to fight the pandemic?
Thank you, Susan. You know, even before the pandemic, psychiatry, mental illness, as you know, takes an enormous toll. The World Health Organization has demonstrated that it is actually above cancer and heart disease in terms of world disability. And the number of people that are affected include every family, and essentially 20% of the population plus to 1/4% or to 1/4 in their lifetime. When you add addictions, it goes well above 50%. And of course, even before the pandemic, and still we're struggling with the opiate epidemic. And the interaction between those is not insignificant. You add medical illness and chronic medical illness, which many people have, and these occur also with aging, and they are exacerbated by disparities of underserved populations, and you can go up to 80%. You add societal issues and trauma and violence and abuse and on and on. So this is the baseline. Then one adds to this the tremendous stress of the pandemic, the complete change and uncertainty with regard to people's lives, the fiscal implications, the political and social turmoil and issues that are broiling in the country, and then the effect of the disease itself on the nervous system. I'm a neurologist as well as a psychiatrist, and we're increasingly finding that in a subset of the population that there are either primary or more often secondary effects on the nervous system that can be chronic for people and can include cognitive and emotional disturbances. Then, and I'm getting to answering your question. I don't want to go on for too long, but it is an important topic. Then you add the issue of the caregivers and the mental health of the caregivers. There was an epidemic of burnout and physician suicide even before the pandemic. And then you have everybody stretched to the max, operating under difficult circumstances heroically. And now we find that that burden and the stress associated with that has exacerbated mental illness and increased the mental health challenges for all healthcare workers, in fact, ranging from people who work on the janitorial staff to the physicians. So what can one do? Well, already, and I think you can speak to this perhaps better than anyone, we in America are, and in the world, are under-recognizing, under-treating, under-reimbursing mental illness treatment. And therefore, the first thing that needed to happen is a ramping up. But then how do you do that? How does one develop the resources, et cetera? To make a long story short, we, like many in all fields of medicine, have transitioned largely on an outpatient basis, except for about 20% of the most ill patients, to telepsychiatry, which has allowed people to be able to receive treatment. It has reduced no-shows. It has allowed people to get the prophylaxis that they need. And it has allowed us to scale our activities. We also are working with communities, particularly underrepresented minority communities and disadvantaged communities, to be able to educate and to provide proactively counseling and resilience building for all the stresses that can occur, and to expand the screening by coordinating with our colleagues in primary care medicine, and so that people don't have to self-identify. And when they get a checkup, they can get their mental health needs checked as well. And so through all of these activities and through the use of groups and also the expansion of cognitive behavioral therapies for groups, we've been able to, and our colleagues around the country have been able to take care of more people. It's a lot more that needs to be done.
But thank goodness we have been able to avail ourselves of the technology of telehealth, as you said, to address those care needs. And in fact, let's hope we're able to pull that forward beyond the pandemic, because as we know, we have a huge shortage of mental health clinicians around the country and really need to address that shortage through these alternative measures.
And for the people who can't afford or don't have Wi-Fi or the technology, the hospital has been working with the local foundations to be able to supply that so that we don't have a built-in hidden disparity in access to even the telepsychiatry and telehealth.
Gerry, I want to go to you next, because one of the major advantages of big system like the VA has is that it is a system. It is a system that has a guaranteed budget no matter what happens. And you've been able to use the resources of the VA to really expedite a lot of very innovative care for veterans, including through telehealth. And despite the fact that veterans are a very vulnerable age group, I think I saw that VA has diagnosed about 84,000 patients with COVID and admitted about 15,000 of them to VA facilities. You've still been able to get treatment to them in very effective ways. Talk a bit about what the VA has been able to do in this situation.
Sure, Susan, I'd love to. I think you probably heard enough from me, but certainly enough about me. So let me now talk a little bit about the health system that I work in. I did have a few slides I prepared. So Yasuto, if you'd be willing to share the slide deck, then I'll go through it pretty quickly, and that'll answer Susan's question and maybe others that you might have. Go ahead to the next slide, Yasuto. Thanks. So as Susan indicated, the VA is an enormous healthcare system, often referred to as the largest integrated health system in the United States. It employs nearly 400,000 people. As I'll tell you, that is tens of thousands more than just a few months ago. There are 22 million veterans alive in the United States, and about 9.2 million of them are enrolled with the VA for healthcare. These tend to be people who are older, sicker, with more chronic disease, a higher prevalence of behavioral health issues, as David was just talking about, of substance use disorders, as well as chronic illness like heart disease, kidney disease, lung disease, and so forth. They are served in a system that has about 170 medical centers, ranging from large tertiary care academic medical centers, mostly associated with major medical schools and university hospitals in large cities, to smaller rural community facilities, and another 1,000 outpatient facilities. So over 1,200 points of care altogether when you add it all together. And the VA is organized into 18 regions across the country. They're called VISNs, or Veterans Integrated Service Networks, as well as facilities in US territories and even one overseas in Manila in the Philippines. Next slide. So just to give you a couple of numbers, including one or two that Susan just alluded to, as I mentioned, veterans tend to be at higher risk for COVID because of their demographics and their chronic disease burden. So far, we've tested over 900,000 veterans and VA employees for COVID-19. We have diagnosed in the VA over 83,500 with COVID, of which almost 15,000 have at one time or another been admitted to one of those 170 odd VA medical centers. As of today, and I checked these numbers this afternoon, so these are numbers accurate as of today, 708 current inpatients, and they're concentrated in the parts of the country that you might expect, right, wherever the pandemic is hot right now. So Milwaukee, North Chicago, Dallas, Texas, Houston, Texas, Oklahoma City, a couple of weeks ago, Phoenix, Arizona, back at the beginning, New York, New Jersey, New Orleans, and so on, Boston. So the veterans population is just as susceptible as anybody else in those parts of the country. And it's important to note that of all of those veterans who've been diagnosed, over 60,000 of them have reached convalescence. That is, they're not active cases, they're not currently hospitalized, they're not among the 4,000 odd who have died, but they've recovered, and so that is good news. Next slide. I wanted to answer Susan's question, talk a little bit about the advantages of being a large national integrated system, because the VA was among the first hospital systems back in early March to take prompt action to protect patients and employees and to reduce the impact of the COVID pandemic. Right away, we made the choice to cancel or reschedule all routine outpatient appointments. So outpatient providers like primary care physicians and advanced practice nurses were redirected or repurposed into providing inpatient care on overburdened wards. Sometimes our nurses and inpatient physicians were repurposed to help support critical care units and provide ICU level care. All of our smaller outpatient clinics, they're called community-based outpatient clinics or CBOCs, were closed, and all elective and non-emergency surgery was canceled for a period of several weeks. It's not coming back up. It's back to about 85% of what it was pre-pandemic. But that shift during the months of March, April into May was critical in concentrating the resources of the system on helping out the patients affected by the coronavirus. We are able to track the availability of hospital beds every morning at the daily operational briefing. We look at how many beds are occupied, how many are occupied by COVID patients, which hospitals have ICUs that are at or near their full capacity, or have med-surg ward beds that are at capacity, which hospitals have surge capacity, have additional beds that they can open if they can staff them to provide overflow care when their regular capacity starts to get full. In addition, the VA took prompt action last spring to protect the most vulnerable veterans in the most high-risk groups. So VA operates, among all those other points of care I talked about, a number of basically nursing homes, right? They're called community living centers. And like nursing homes anywhere, some people are there for a short term for rehabilitation, some are there in hospice, but many of them are traditional, which we think of as long-term care patients with chronic disease, with dementia, and with the need for assistance with the activities of daily living. So right away, we restricted visitors from all our CLCs. We've seen that done in nursing homes around the country since then. There's been a universal mask mandate in place for visitors and employees at VA hospitals. Of course, screening of everybody who comes through the door, temperature screening, getting asked screening questions about symptoms and exposure. Every morning when I walk into my building at the headquarters, it's not a healthcare facility, just an office building, but I go through the same screening process. And we are continuing, even to this day, to test all inpatients on those community living center units, those long-term care units, as well as other vulnerable groups of veterans like spinal cord injury and spinal cord disease patients. Next slide. Another thing that is somewhat unique about the VA, although actually an awful lot like the military, is the ability to mobilize and deploy forces, including healthcare personnel, to areas where they're needed. The system is called DEPS, the Disaster Emergency Medical Personnel System, but it's a system where healthcare workers, registered nurses, licensed practical nurses, pharmacists, social workers, physicians of all types can volunteer to go to a spot where there's a need. So recently, this year, a lot of hurricane support in places along the Gulf Coast, New Orleans, Florida, and so forth, but out to the areas of Northern California, Oregon, and Washington State to help support facilities impacted by wildfires out there over the summer, but on an ongoing basis since March now in terms of a COVID response. So the VA can move resources, not just people, but other resources to where they're needed most. Back in the spring, again, it was New York City, Northern New Jersey, Chicago, New Orleans, and we were able to move ventilators, to shift personal protective equipment or PPE to those spots. And now, as the pandemic has shifted in location to wherever it's hottest now. The VA has the advantage of having purchasing power as a large national system that can let large national contracts to purchase PPE, to purchase medical equipment and supplies. And most ingenious is when certain types of supplies, like the nasal swabs that are used for COVID testing, were running low because there was a global shortage. The VA was able to turn its 3D printing network on. So there were a number of hospitals that had sort of independent 3D printing capabilities that use them to make certain medical devices. Well, they were linked together in a national integrated network, and we're now turning out our own face shields and turning out our own nasal swabs. They're all appropriately FDA approved, but that helps to supplement the global supply chain. In addition, the VA was able to hire tens of thousands of new employees very rapidly. I told you that there were close to 400,000 employees in this massive system. 59,000 of them have come on board since the end of March, including over 11,000 registered nurses and nurse practitioners. You know, when I was hired 7 years ago, it took 4 months, and I'm not a healthcare provider, right? I'm administrative overhead, but it took 4 months from the time that I received the tentative offer of employment until getting through all the hiring and credentialing and screening processes. That's way too long in a crisis like this. So we've gotten that down to a matter of a few days, even to hire and temporarily privilege new physicians and advanced practice nurses. So that has been a remarkable help in responding to the pandemic. Next slide. Another thing that's remarkable is the incredible shift toward providing virtual care from face-to-face visits, because obviously that's dangerous. We actually don't want vulnerable patients coming to clinics and hospitals, even as we've begun to reopen them, because of the risk of exposure. So the physical bandwidth, the infrastructure for telehealth, and the training of tens of thousands of healthcare providers to perform virtual visits was key to enabling this incredible success story. The VA thought it was a leader in telehealth back last February, with doing about 10,000 visits per week. So the last week of October, there were 180,000 virtual visits delivered. That's a 1,500% increase in home or offsite telehealth visits, meaning that's not, you don't make a veteran come into a clinic facility in some small town where they can connect by video with a specialty provider, maybe at a larger VA facility in a remote area, a distant area where they have more specialized services available. You can do this from home. So veterans do this on their smartphones, on their tablets, in conjunction with commercial partners. Veterans have received donated tablets and smartphones in parts of the country where there's a shortage, working also with broadband providers to increase the available bandwidth, Wi-Fi access in some of those more rural areas of the country to enable this telehealth capability. Next. And then I'd like to just spend a minute telling you about something that most people don't know about, and that is VA's role to supplement the National Disaster Response System. The traditional three roles of the Veterans Healthcare System are clinical care, right, taking care of veterans, education, something like 70% of all US physicians at one time or another work in a VA hospital, whether it's as a medical student, as a resident, as an employee. And then there's a large research and development mission that the VA has. But the so-called fourth mission is to improve the nation's preparedness by responding to national, state, and local emergencies. And that is something that doesn't get a lot of press. Next slide. I'll expand on this a little bit with the next slide. Thanks, Yasuto. So the 13 states in the dark color on the map are those where non-veteran patients have been cared for in VA facilities. So these are what you might call humanitarian civilian admissions, supporting the local healthcare systems that have reached capacity and are overflowing. Over 2,000 VA staff members, many of them clinical staff members like nurses and healthcare providers, have been supporting non-VA facilities. They've gone into to local private hospitals or supplementing public hospitals, in many cases supplementing the state veterans homes, because many US states run their own veterans health systems, and some of them have become quite infamous for not providing a very good quality of care. There have been some really tragic high rates of infection and death in state veterans homes that you might have read about in New Jersey and Massachusetts and elsewhere. The VA, because of its leveraging power to purchase PPE, has supplied masks and gloves in the hundreds of thousands to other parts of the US health system, conducted 56,000 COVID tests, supporting the needs of states that didn't have the capacity, and so forth. Next slide, please. So that's the so-called fourth mission. And then wrapping up here, I want to tell you that all of this is done with a tremendous amount of reporting transparency. This is a public website, accesstocare.va.gov. If you go there, you can read today's statistics, and I did this screenshot this afternoon. So those are the numbers as of today of veteran cases and non-veteran cases as well, of admissions and of deaths across this whole system. The blue circles on the map each represent a VA medical center. The size of the circle represents the impact of COVID at that medical center. And it's an interactive map. If you go to that website, you can click on any one of them and you get the specific numbers for that VA medical center. But the roll up there on the left are the numbers for today. So VA turns out to be a pretty agile system, and one that was able to respond quickly when the need arose. Next slide, please, Yasuto. And highlights of the COVID response have been a tremendous shift toward telehealth, towards what are now common practices everywhere, like screening for visitors and employees, universal mask wearing, and restricting visitors to the nursing units, long-term care units. Also, we're able to expand our capacity to support other parts of the U.S. health system. And using real-time information, like on that interactive map I just showed you, has been a key to success as well. So Susan, I think I gave you more than the answer to your question, but if you have others as we go through, I'd be happy to answer them as well.
Great. Thank you so much, Gerry. And it really is extraordinary, the response that the VA has been able to achieve in this crisis. So Hal, I wanted to go to you next. The healthcare system across the country has been under enormous stress since at least early March. Staffing shortages, which we're now coming up against again, personal protective equipment shortages, many places now in danger of maxing out on their ICU capacity, big financial stress on the healthcare system due to the suspension of elective surgeries and the fact that many patients who are sick with other things just aren't showing up for medical care. There's been a truly worrisome fall off in the number of people needing cancer screenings, for example. And I'm sure as a urological cancer specialist, that is something you find particularly troublesome. Tell us how things have been going at GW, obviously a very prominent academic medical center in the Washington, D.C. community. How are you doing? How are you responding, particularly relative to other systems in the country? And what are the biggest challenges you face as a system?
So really, thank you for the question. It's a multiple layered question. And I do have a few slides as well that I will share that might help with some of this. So let me pull those up for us. So what we ended up finding, I'm currently sitting as the chair of the board of trustees. So I was deep in the weeds and all of the actions that we took in the early part of this phase. And let me run through a couple of things very quickly. COVID, everybody knows what it's about. It hit us back in 2019 in the world when the Wuhan Municipal Health Commission reported the first cases. The first case in the US occurred was noted in Washington State on January 20th. Wuhan went under quarantine 3 days later, and then January 31st, we hit a WHO global health emergency. The first case in New York was in March 2020, March 1st, and then the 7th of March is when we saw it in DC. So there was a huge, very rapid ramp up of cases. So you can see by these are the number of cases in New York City.
Al, do you want to go ahead and click on slideshow there at the top of your screen so you can advance the slides? We're seeing the
oh, okay.
Deck. Yep.
Sure.
Yep. Great. Thank you.
Do you see it now?
No, we're still seeing the hopeful menu, but if it's going to be a problem, don't worry about it.
Well, if not, here, let me try it a different way here. You don't see it. Okay. Well, let me just talk through this then, because what we
see the slides, but they're not advancing. That's the problem. Yeah.
Not advancing. Oh, that's
yeah.
Interesting. Okay. Well, anyway, what we found is that New York had a very rapid uptick, and they peaked in April 2nd, and the number of hospitalizations peaked on April 2nd. And by April 9th, the death rate peaked in New York. So we actually in Washington, D.C. did not have the same rapidity or quick rise as we saw in New York. So we had some time to adjust. And what we ended up doing is pulling together a lot of the resources in our community. We developed a command center that had 24/7 staffing. We converted 200 rooms over to negative pressure, where we would move air from the room to the outside world instead of into the hallway where staff would be exposed. We changed the OR configuration to negative pressure. We had contingency plans for surge volumes up to 150% of capacity, and the redeployment of nursing and residents and attendings. We also tapped into resources in our local community at GW, where we changed out or retrofitted a 600-bed dorm for convalescents and the convention center was converted to a field hospital with Mayor Bowser's help. We had great cooperation with the DC hospitals, and we then moved on and started trying to share a lot of our PPE. You mentioned the PPE issue. We had a major stocking issue. At GW, we had just ordered or restocked our Ebola emergency supplies. Back in October 2019, it was fortuitous. At the time, we had 45,000 masks, gowns that were available, eye shields, and chemical cleaning equipment. We developed a ventilator agreement between all the hospitals, including Children's Hospital in Washington. Our biggest challenges was severe shortages of PAPRs, or powered air purifying respirators. So we had to become creative. We tapped into the State Department. We do a lot of emergency work here in DC with the State Department and with the military, so we're able to tap into that. But like Gerry mentioned, we shut down visitors. We did not allow visitors in the hospital except for terminal patients. We started screening processes. All sick employees were asked not to come to work, which, as you mentioned, created staffing issues. We created extensive contact tracing efforts, and we quarantined anybody if they had high-risk exposures initially. We've created testing and exposure algorithms that were implemented and evolving, and we're currently on version 20 now. We've gone through a large number of changes. During the surge, we provided hotel rooms in the local community for personnel who wanted to avoid being exposed, exposing their family, provided free meals and dorm rooms for COVID positive staff and residents. Child care centers shut down. We provided free child care and free Uber rides and lifts. But we've received huge number, hundreds of donations during this time as well. So in total, we ended up having over 2,000 positive tests just at our hospital. But the toll on the staff, as you already talked about, was extensive. Long hours, a lot of exposures, constantly in and out of PPE. Yet in spite of all that, our conversion rate of healthcare workers has been extremely low, mostly because of the fact that we had these protocols already in place, ready to protect people and make sure that we provided care if they had any issues. Our prevention at GW was built upon hygiene, distancing, screening, and unmasking. And there's plenty of data to show how that makes a huge difference for us. We went through our surge. The surge in New York was April 2nd. The peak of our surge was late April. As anyone in DC knows, we are surrounded by 4 counties, 2 in Maryland and 2 in Virginia, Montgomery County, Prince George's County, and then the 2 in Virginia are Fairfax and Arlington. And we have done a lot of collaborative work with those hospitals, but the toll has been tremendous. You know, ironically, in the midst of all of this, we had the largest cyber attack ever in the history of medical care and the universal health system, which GW Hospital is part of. So that took about 2 weeks to ramp up our EMR systems back up online again. During the COVID surge, we shut down all the operations. The hospital lost in the range of the 8 figures and $80 to $90 million. No elective surgeries, no elective procedures were done. UHS is a large hospital system that was able to kind of absorb some of that. But I know a number of hospitals around the country. I'm on a weekly call with a lot of leadership around the country and the hospital systems, and they're struggling. The finances are they're constantly in the red. Within our medical system locally, we have 3 corporate entities, the med school, the hospital, and the medical group, and they're all in the red. They're all trying to figure out ways to balance the budget. It's a very challenging time. We're getting very creative. The hospital has actually ramped back up to nearly full capacity again here as at Washington Hospital Center, Georgetown, but we still are in a hole in trying to keep people employed. We did have to furlough a number of people for about 2 months just because of the shutdown and the fact that there were so few patients in the hospital that were having elective care, because they were filled with patients that were really critically ill and or dying from the disease. So it was it's been a challenging time. I'm glad a vaccine is coming. That will help provide some relief in the next 6 months to 12 months, but it's not going to be tomorrow. And we are very concerned about the mental health of the healthcare workers and the staff in the hospital. We were constantly every week on phone calls with all the leadership, trying to figure out, make sure that we have adequate resources available. PPE is not currently a problem, at least in our region here in DC. They are in other regions around the country, but we're doing okay right now. But we're more worried about the personnel.
Well, thank you very much, Hal, and for extending this very troubling and sobering picture for all of us. We have just about 10 minutes left, so I'm going to try to work our way through a couple of questions that have come in from the audience. And maybe if you all could keep your answers relatively short, we'll be able to get through all of them. But one question really has come up from Peter Kilmarks about the distribution of the vaccine. As we know, relatively few doses are going to be available, even if the Pfizer vaccine, which has gotten very good results, at least in the initial phases, is approved. Pfizer only has capacity for about 20 or 30 million doses of the vaccine for the world in the short run. How are people thinking about the challenges around distribution of the vaccine? We know that priorities have more or less been set about getting the vaccine first to the highest risk groups, including to essential frontline healthcare workers. But obviously with 20 or 30 million doses of the vaccine, maybe we'll get lucky and have more vaccines and more capacity, but this is going to be a huge, huge challenge. And so just briefly, Gerry, how is the VA thinking about addressing this challenge?
Sure. There's an entire task force that's been working for weeks already to prepare for the receipt and distribution of a COVID vaccine, led by a physician named Jane Kim, who's our chief consultant for preventive medicine and public health. Dr. Kim's group not only has established those priorities that you mentioned for who should receive any vaccine first, frontline healthcare workers, first responders, the most vulnerable patients, elderly, veterans with chronic disease, those nursing home residents and so forth. But they've also addressed the challenge of how to distribute this on a national scale. In particular, one of the challenges associated with the Pfizer vaccine candidate is that, first of all, it requires 2 doses a month apart, right? So it's not a single injection. Secondly, it has to be handled very carefully. It requires extremely low temperature storage, minus 70-degree storage, which requires special freezers that most hospitals and certainly most doctors' offices don't have. So we've had an inventory of which VA medical centers indeed have a minus 70-degree freezer. And if that's in a part of the country that where the need is greatest, that's a happy coincidence. But it's equally likely that some of those low temperature freezers are in parts of the country at some distance from where the pandemic is raging the most. And so we're establishing supply chain processes and procedures to maintain that cold temperature while shifting lots of vaccine from perhaps from one part of the country to another.
And David, how is Brigham and Women's thinking about these challenges?
You know, it's Harold gave a phenomenal description, and I would say that ours parallels what those folks are doing down in Washington, D.C. Our surge initially was pretty high, and we shut down everything. We went through all the same measures, and then the big question became how one continues to take care of people who need other acute medical care, and are they coming into the emergency room and getting the care that they need because of fear of the virus, and how can we establish the fact in people's minds that it is safe to come back. In fact, the hospital is a very safe environment, and transmission rate has been very low. There was an outbreak at the Brigham that reached a few dozen cases and was all traced and tracked, and that provided a reminder and an incidence of sort of resurgence of command and control mode. And right now we're watching the numbers go up again in Boston and worried about another surge. And of course, there are all the universities in Boston as well. So I think, and similarly, as was mentioned, there's a lot of cooperation among the hospitals in Boston. We also stood up a complete new hospital out of nowhere, and I think our military colleagues would be proud. And it was a 1,000-bed hospital that had all the specs and took a lot of the patients who were less acute, but who nonetheless needed care, so that the sort of mothership hospitals could take care of the sickest of the sick. We never maxed out the ICU capacity, but part of our concern was the moral hazard and the mental health sequelae if things reached a point where people had to decide who got ventilators, et cetera. Thankfully, that point was never reached, although there are parts of the country now that are in quite desperate shape.
And in terms of thinking about vaccines and administering vaccines.
Yes, and I'm sorry if that was the initial intent of your question.
No,
yeah, the same thing, really. The issue is logistics and access and triage, and making sure it's done equitably as well. Of course, in Boston, Cambridge, we have a lot of the main biotech companies, and but at the same time, there are a lot of protocols and a lot of empirical testing going on to make sure that nothing's rolled out before it's safe to do so.
Hal, I'm going to switch gears a bit and go to another question that has come in from actually from two of my classmates, Maura Harway and Richard Mark, which speaks to this lack of seeking of medical care by many people who needed medical care during the crisis. And as we mentioned, given your specialty in your urological cancers, I'm sure you're very, very worried about this phenomenon. What do you think is going to be the end result of this lack of care for many people in the crisis, as we've been so focused on delivering care for people with COVID?
Yeah, I think there's an underlying epidemic that no one is really talking about, and that is the normal diseases that we see throughout the typical year are not getting cared for. As you said, even though we are trying to ramp back up to normal numbers, we are still only about 80% of our normal volume right now, not only in the hospital, but also in the operating room. The numbers that I have seen, and this is a number that I'm coming from the epidemiologists, is that our total death rate in the country above and beyond COVID is 100,000 more than it normally is. And these are cancer related and cardiovascular related deaths. As an oncologist and having been down this road myself, there are a lot of patients that just won't come in. They'll do telemedicine, but then we need to do additional testing that requires them to come in on site, and they're not willing to do it. And so it is of a major concern to us. The fear of COVID is so great that they're willing to put these other medical conditions on hold. So it's a legitimate question, one that we are very concerned about, and is actually not being discussed to any great degree right now. So it's a great question. Thank you.
And I'm going to take the liberty of just quickly saying a word about another question that came in about rural health care. And we know that many of the hotspots now emerging in the country are in rural areas where, if anything, the systems, healthcare systems are even more compromised. There's even less ability to augment exhausted staff with other staff. Nobody's traveling to new parts of the country now to provide healthcare. We know that those smaller rural institutions are particularly vulnerable to PPE shortages. I talked to a colleague who's a critical care nurse out at a hospital in Western Colorado, and literally they are down to using plastic bags for PPE in some occasions. So this is a real crisis, the likes of which none of us has seen in our lifetimes. And I just want to close by asking each of you, we know that we have limited tools at this point until there are effective vaccines and more effective therapies. We know about the importance of wearing masks. We know about the importance of social distancing. We're steamrolling into the holiday season when so many people would be otherwise inclined to get together, see relatives, et cetera, especially after all of these months of periodic quarantine and shutdown. please, in 30 seconds, give advice, each of you, to everybody on this call today, and give some advice to the president-elect and others who are going to be having to grapple with this crisis into next year. Gerry, I'm going to start with you.
Sure. Well, this is not something that everybody hasn't heard already, but I'll channel Anthony Fauci. Wear your mask, keep apart, don't engage in large gatherings or even small indoor family gatherings. You know, in our own family for Thanksgiving, we've already decided it's just going to be Kathy and myself and our daughter Caroline, who's going to get tested before she leaves campus to come home. My mother-in-law, who's a fairly healthy 85-year-old who lives alone in a retirement community, has decided the risk is too great even for her to spend Thanksgiving or Christmas with us. So we'll, try to join her virtually in a Zoom call like this, but it's not going to be a typical holiday. The other piece of advice is listen to the scientists, listen to the healthcare professionals, don't listen to the politicians.
Hal, let me go to you next.
I would agree. Your family gathering should be your small bubble of family that live in that household, and that should be your Thanksgiving. If you invite more people into that household, you're putting yourself at a larger risk. I would echo what Gerry says. I don't have a lot more to add to that. Please listen, because the science is there. Sadly, America, there's a subset of our population who believes that science is just another opinion. And that's unfortunate because that's really what's causing spikes now around the country.
And last word to you, David, and please feel free to address our mental health issues too.
Yeah, I would say that isolation that was just alluded to is really important for public health reasons and epidemiologic reasons, but increases the risk, especially for the elderly, and yet is really important so that people stay safe. And so the issue is how we mitigate the loneliness and the depression and disconnectedness that comes from that. And I think the more everyone can reach out to family members and friends and coworkers who may not have other people in their lives, to people who've lost their job and maybe having financial issues around the holidays and identity issues around that. These are things that, as a caring community, we need to do for each other. And so I would say take care of your own mental health because it's a marathon and you need to stay strong, stay protected, but also stay connected.
Well, I want to thank all three of you for a very sobering, troubling, in other ways, exhilarating, particularly hearing about the response of the VA conversation. So again, thank you. And Gerry, once again, congratulations to you. And now let me turn things back over to the Dartmouth Club folks.
Thank you, Susan, and thank you to all of our panelists tonight. It's a very difficult topic and a difficult time. We appreciate you sharing your areas of expertise, and we know we'll get through this together. Just in closing, want to do a couple of final quick things here. One is just as we acknowledge again Gerry's reception of this award, wanted to invite everyone to unmute themselves and just give a quick round of applause to Gerry, if you're willing. So. Great. And then finally, we typically sing the alma mater at the end. We have a couple of slides in here for that. I'll allow everyone to just reminisce on the words very briefly, but we won't make an attempt to sing it virtually. Feel free to Google Dartmouth alma mater right after it and play it for yourself. The Dartmouth Airs have a great rendition on YouTube. But we do thank you all for joining us. Wanted to also just thank our Webster committee, specifically Alex, Meredith, and Liza for their diligence in putting this work together and adapting to the virtual event. Kevin, who put all of these slides together and has just generally been helpful, kind of helping to run this event in the background. Erica for communications, and Bob Davidson for continuing to pick up the awards and get that delivered to Gerry. So thank you to all those who participated in helping to make this happen. Finally, we just wanted to just invite anyone to participate with the Dartmouth Club of DC. If you're so inclined, we're always looking for new ideas, new board members. So you can reach out to the Dartmouth Club of DC at gmail.com. And we always do make the selection of the Webster Award recipient a democratic process. So if you do know of others who you may want to nominate for next year, again, feel free to email the Dartmouth Club of DC at gmail.com. And you can find out about our further events at dc1.dartmouth.org. Thank you all again for joining us tonight, and we hope you have a great rest of your night.
Thanks, Itsuto. Bye-bye.